Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features expert insights on ART safety and tolerability in aging patients with HIV. During this podcast, Dr. Marta Boffito and Dr. Julian Falutz discuss their approach to ARV medications in older patients with HIV. For more information about Dr. Boffito and Dr. Falutz, and for a link to the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started and hear what they have to say about this topic.
My name is Marta Boffito, and I work at Chelsea Westminster Hospital in London.
Hello, and I'm Julian Falutz, and I work at McGill University in Montreal.
In the literature, data are available to show that people living with HIV who are aging are actually still on protease inhibitors a lot. As you know, protease inhibitors can provide a major benefit in the presence of extensive resistance, of course. But do we actually need everybody who is on protease inhibitors, especially if they have polymorbidity or are on polypharmacy, to continue with the protease inhibitors? So the percentages we are seeing in the literature are between 25 and 45%. Is this really needed? Because the challenges with boosted protease inhibitors use are indeed the drug-drug interactions, because the booster inhibits cytochrome P53A4, which is one of the major metabolic pathway for very many medications, but also GI intolerance, hyperlipidemia, and cardiovascular risk, especially for some protease inhibitors. Polypharmacy, this is really important because it's becoming a common clinical scenario in our clinics. Polypharmacy is just the use of 5 or more medications. The reason why it's really important is because increased medication use has been clearly associated with pill fatigue and therefore low adherence, increase of adverse drug events, increase of drug-drug interactions, as we said, also geriatric syndrome, so increase of falls, cognitive impairment, frailty, but also mortality. So we know from the literature that polypharmacy is one of the strongest predictors of serious adverse drug events, and again, drug-drug interactions and fall risk. And also, a dose-response association has been shown with all-cause and cardiovascular disease mortality. So it's something we really need to keep an eye on. So we have to think about deprescribing. And in the HIV field, deprescribing can be divided in 2 areas. Deprescribing in the context of antiretroviral treatment. So in people with an undetectable viral load with limited resistance that can switch off drugs characterized by a high potential for drug interactions like boosted antiretrovirals, we probably start to think, can we give them a lower pill burden, drugs with less drug-drug interactions, with less toxicity? That's part of the deprescribing. And then very importantly, we need to learn about deprescribing in the context of non-antiretroviral drugs, which is something, geriatricians probably think about every day. But because people living with HIV sometimes do expect that we are involved in their holistic treatment, we need to become knowledgeable about it. And deprescribing in the context of non-antiretrovirals means discontinue inappropriate medications, being brave enough to discontinue appropriate medications, maybe with the help of a specialty, a geriatrician, a GP. But we have to look at that. We can't continue to see people who are the age of your patients in clinic that come on 25 medications. Some are probably not needed. So we also can consider those reductions, medication switches, simplification, and obviously use evidence-based options that are feasible and safe. We need to have conversations with the people we see in clinics. They might be very attached to some of the medications. They might not need them. So it's very important that we are knowledgeable and confident about deprescribing. Obviously, deprescribing requires follow-up because there are some potential risks. There could be withdrawal syndromes. There could be drug-drug interactions changes, pharmacokinetic changes. So that's something important to keep an eye. But obviously, our goal is to manage polypharmacy and reduce the risk for drug toxicity, interactions, and obviously improve outcomes. So, of course, it's important that the prescribing happens under the supervisions of healthcare providers. But I think it's a job we need to do together with people we see in clinics to make sure, again, it's safe and it's welcomed.
Well, one of the things that you're highlighting, which is very important, is that it's a dialogue. And so we need to be able to talk to our patient. The patient needs to tell us about the medications, why they still want to continue something. So in addition to thinking about these very important things, as you're recommending, we also need to establish a dialogue about why we're having this discussion rather than just recommending we're going to stop this or we're going to change this.
Absolutely. I really agree. And that dialogue might lead to no switching or stopping a drug there and then, but just start, kind of implementing a cultural change so the prescribing can safely happen. Absolutely. Why am I talking about non-antiretrovirals? Well, a study that we published a few years ago, which is one of the analyses from the POPI study, which is a cohort study happening in the UK and Ireland, looking at health outcomes of people aging with HIV, demonstrated that polypharmacy and drug-drug interactions are more frequent in older and younger, but especially older, people living with HIV compared to people without HIV. But very importantly, this is true, obviously, when we consider drug-drug interactions between antiretrovirals and non-antiretrovirals, but it's also very true when we consider drug-drug interactions between non-antiretrovirals and non-antiretrovirals. Sometimes the people we see in clinic are on so many medications that they might have adverse outcomes from drug interactions that have nothing to do with protease inhibitors that we mentioned earlier. So this is something, again, that underlines the importance of our mindset to focus on AG polypharmacy and the prescribing when it's needed. How do you manage such a complex clinical scenario?
I think one way to start to address this, and just for a quick comment about the polypharmacy, is that I think we as physicians sometimes, especially patients we've known for a long time, get into a situation of complacency. And we see as, everything is fine. There's no obvious toxicity. So I think the idea of a medication reconciliation with a knowledgeable pharmacist on an annual basis at least is a very important principle to follow, because we ourselves, and I find myself forgetting this, is that we need to review why somebody is on something. So the comment about a medication reconciliation, I think, is one of the most important take-home messages. As to the multimorbidity, multi-complexity of this patient, obviously, these did not happen all at one time, and they happened progressively over a long time. And luckily for this individual, most of them are stable, but I have to keep reminding myself of them. And obviously, you can't think of all of the problems at each visit. So you have to decide, what are you going to focus on today? How often are you going to see the patient? Now the recommendations are for immunologically stable patients. We see them once or twice a year. We check their levels. Everything is fine. But obviously, in a patient like this, there are other considerations. You can't review all of these issues. You can't review all of the medications at once. So general advice that I give is, I set myself goals. Today, we're going to focus on this set of problems. Ask the individual, what is important to you today? What are you dealing with? What are your concerns? Let's deal with that. We're not going to get to all of these issues, whether it's diabetes management, whether it's diet, whether it's the blood pressure medications. I'll see you again, not in 6 months and check your viral load and CD4, but maybe I'll see you in 3 and 4 months. So as a general principle, for things that are stable, obviously, if things need to be managed acutely, or we will deal with them. But for general, with all of these comorbidities, make yourself a plan. Base it on what is important to the patient and see him as needed for the management of these issues. Thinking of it in that way, the question is, how well are our patients doing? And we know that most of our patients are doing very well. But we also know that in general, the long-term survival of most patients, certainly not everyone, is a little bit less than that of the general population. And the main reason for that are due to the complications which occur earlier than in age-matched individuals. And these complications can be seen in terms of medical comorbidities, but increasingly we're starting to think of many of these conditions as what we refer to as traditional geriatric syndromes. So we know about the comorbidities. We know that at every age, persons living with HIV have more non-HIV comorbidities than age-matched controls. And in this classic study by Giovanni Guaraldi from Modena, he clearly showed that starting even at the age of 40, persons with HIV had more of the age-related comorbidities, whether they were diabetes, cardiovascular disease, bone demineralization, than persons without HIV. So we know that, we're aware of that. However, as I mentioned, in dealing with the sort of the new thinking about geriatric syndromes, we need to start thinking about these. What are geriatric syndromes? They're conditions which don't fit into discrete disease categories. They most of the time have multifactorial etiologies, and they involve multiple organ systems. And the common ones that we think about are polypharmacy, which we've discussed, sensory impairment, decreased vision, decreased hearing, impaired smell, pain, and polyneuropathy are also important. Impaired mobility, impaired function, increased incidence of falls are typical geriatric syndromes. Obviously, people are aware about cognitive impairment with HIV, but as our patients age, we're talking not just about HIV-related consequences or antiretroviral-related cognitive impairment, but age-related complications, vascular risk factors, degenerative cognitive impairment, Alzheimer's, the typical one. We also see increasing frequency of bowel and bladder dysfunction in persons with HIV, and sarcopenia, which is the loss of lean mass in combination with impaired muscle strength and function. And of course, the typical, if you will, geriatric syndrome of frailty, which is a state of vulnerability for the development of adverse events. And the study on the right shows many of these geriatric syndromes are present more often in persons with HIV, even at a younger age, in the high 50s or early 60s, compared to age-matched controls. So in terms of polypharmacy, which we've discussed, and looking at the non-antiretroviral medications, I think it's important to keep in mind, some of the general principles of the major drugs or drug classes to avoid in older persons with HIV. We know that a lot of the over-the-counter medications, antihistamines, anti-allergens, have anticholinergic effects, which can lead to falls, which can lead to cognitive decline, etc. Tricyclic antidepressants, the older medications, also have anticholinergic properties. And we know that many older patients have been on benzodiazepines, for many of them, unfortunately, for a long time. And we should always be very aware that we need to discuss this, because clearly after all of these years, they're not really effective, but people are very used to them. They rely on them. So we have to bring them into the discussion about the potential toxicity of them and do a slow taper for some of them. We don't recommend stopping drugs suddenly. We don't recommend tapering multiple drugs at the same time. Do one at a time, but work with your pharmacist. That's the important thing. We know that persons with HIV use atypical antipsychotics, the short-acting ones. Many people, unfortunately, use them as sleeping medications, and they put themselves, or they are put at increased risk for some of the side effects. Some of the anti-diabetic drugs, especially in older patients, especially, we have to be aware, think of diabetes. Look at the A1C. Many patients have a diabetic control that is very, very tight. There are obviously recommendations as to, how to manage this carefully. And cold medications, we always have to be aware. Again, many over-the-counter medications, and that's, I think, the key point here, have potential for toxicity, drug-drug interactions, which we should be aware of. So you mentioned that some of the boosted POIs can also interact with many of the non-antiretroviral medications in terms of the anticholinergic effect. What specifically has been your experience?
Yeah, absolutely. So we have experience in reviewing the anticholinergic medications and making sure that they're not taken in older people if they're boosted by cobicistate of ritonavir. So again, that would require a thorough antiretroviral and co-medication review. Now, presented at CROI in 2022, from, again, the POPPY study, were very interesting data on the use of anticholinergic medication in older people living with HIV. because they showed that the most common prescribed anticholinergic medication, first of all, were called citalopram, loperamide, amitriptyline, diazepam, and cetirizine. So some of them can be increased by boosters. Citalopram, for example, is partially, but it is metabolized by cytochrome P453, as well as loperamide, as well as some of the benzodiazepine. So we have here people aging on anticholinergic medication where the concentrations of these medications can also be increased. And very importantly, the study showed that the risk for falls and for meeting the frailty criteria is higher in people using anticholinergic medication versus people who don't. Just to confirm what you just explained to us from your experience. Now, interestingly, you spoke about neurocognitive impairment. I think it's also important to remember that some antiretroviral drugs could be associated to neuropsychiatric adverse effects, such as insomnia, sleep disorders, dizziness, anxiety, depression, headache, poor concentration. These are some side effects that characterize integrase inhibitors, such as dolutegravir, but also bictegravir. Cohort studies have been shown that discontinuation rates seem to be slightly higher for dolutegravir compared to first-generation integrase inhibitors. The amount of people who experiences the neuropsychiatric side effects that lead to discontinuation is quite low, but we need to remember that because, again, we're already talking people with multimorbidity, potential geriatric syndrome, neurocognitive impairment, and we're talking about switching to high genetic barrier integrase inhibitor is a good thing. I personally think it's very helpful, but let's not forget about the side effects of the new drug that we introduced. Now, the key take-home points from this conversation are indeed that older people living with HIV are at increased risk of age-related comorbidities, premature aging, such as geriatric syndrome and polypharmacy. The use of deprescribing, again, both for antiretroviral drugs and non-antiretroviral drugs, when appropriate, can really help address and reduce polypharmacy and geriatric syndrome, some aspects of the geriatric syndrome. So when we can, we should switch patients off antiretrovirals that are associated with an increased risk for drug-drug interactions and therefore adverse drug reactions. But also we should think about non-antiretrovirals and discontinue unnecessary and inappropriate medications. We also should remember we should be cautious when we use anticholinergic medications, as the use of these drugs has been associated to increased risk for falls and frailty.
Thank you very much to Dr. Boffito and Dr. Falutz, and thank you to our listeners for joining in. As a reminder, to view the full, state-of-the-art, applying up-to-date safety and tolerability data to individualized HIV care program on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back for more episodes on important infectious disease topics. Thank you.